Hello, hi, this is Dr. Scott Hutchison here in Tucson, Arizona. I'm a reproductive endocrinologist in private practice and also work through Banner University Medical Center and with the Department of OBGYN here in Tucson. And tonight's Hutch's Huddle is about polycystic ovary syndrome. And with me tonight is Dr. Erin Sperry, who's a fabulous general OBGYN who was one of our residents here in Tucson. Dr. Sperry did her undergrad at Harvey Mudd College and was originally a computer scientist. After working in that field for a few years, she decided she wanted to go to medical school. She went to Albany for medical school and then came out here to Tucson for her OBGYN residency and is now working in private practice at Crossroads Genesis. And if you're looking for a great general OBGYN, I highly recommend her. But today we're going to talk about polycystic ovary syndrome, kind of both from the perspective of general practice management and also then from and dealing with harder cases that then we may see in more academic practice. So let me welcome Dr. Sperry.
Hi, Dr. Hutchison. Thank you for having me on here.
Oh, you bet. Oh, this is fun. So anyway, Erin, is there anything in particular that you find particularly helpful about this kind of thing for patient education?
This format, you mean? Yeah. I mean, I think it's great to be able to reach out to people and educate people a little bit, both before I see them in the office, because I think when people come into the doctor's office, they sort of get this deer in the headlights mentality. And so I think a lot of times, you kind of tell them everything you can and you hope some of it sticks. But then I think, I love it when people have come in and have been reading about their condition that they think they might have, or if they then go home and read about it and then call the office later. And so I think it's great to be able to reach out to people at home who are, maybe just hanging out at home, or we're watching TV or have just finished up dinner, and to be able to kind of get more education out that way.
Yeah, I agree. Polycystic ovary syndrome cases used to be relatively far and few between. I think in our division in Baltimore, we had 3 fellows a year, and we had half a dozen faculty members, and probably per week we had maybe 6 patients total, and trying to educate those patients in an hour or hour and a half kind of just was almost impossible. So having them be able to get to more, or, to see more stuff before they ever come in here, I think is super, super helpful.
Yeah, absolutely.
Yeah. So, how many do you see in a week, do you think?
In a week? Oh, I mean, I see it every day. I see women with polycystic ovarian syndrome daily. And I think some of them know they have it and some don't. And it's the first time they're hearing it, and they're seeing me for other reasons like irregular periods or hair growth or acne or something. And so, I mean, I would say 6 a day. It's just so common now.
Yeah. Yeah, it's crazy because when you look up incidence of polycystic ovary syndrome, if you start plowing back through the papers, you'll see, like from 2007, there was this one, it's like 7%. Mm-hmm. And then year by year, it just keeps going up every single year. And so I don't know. Do you have some feelings about why that's so much more common now?
I think a lot of it has to do with the American diet. And I think there's so many foods with like hidden added sugars that people are getting. And I think, our lifestyle these days, that most people aren't living in a place where they're able to be as active as they'd like to be. And I think that combination of, the bad food that is what is available. And I eat Cheetos when I'm on call too. You kind of, you get hungry and you reach for what's there. And I think there's so many just hidden extra sugars. And I think it's really this high carbohydrate diet that we tend towards, everyone has in America,
Yeah, it is. It's really pretty creepy. I was watching television with my daughter when she was home a while ago, and we were watching some sort of commercial. It was like sports or something, and they had a lot of food ads on there. And after about an hour, she looks over at me and she goes, nobody should eat any of this food that's been advertised. Like none of it. I mean, it's all bad.
None of it's food, it's
Right.
it's all like snacks and treats, and none of it is really essential to what we need to sustain ourselves.
Right. Right. Yeah. But heavily marketed, man. And
oh, for sure. Yeah.
And with very dubious claims,
Yeah.
But yeah, have you looked at the old paper, the first paper from 1935 in a while that I know that was probably gone over in Journal Club, a long time ago.
A long time ago.
Yeah. So, I always think back to that, and, it was Chicago. So it was these two GYNs in Chicago named Stein and Leventhal.
Mm-hmm.
And, Chicago was one of the first places, well, a lot of places had, New York had a subway, but they got an elevated railway, and, the quality of day-to-day life was getting better for people, and people could afford more.
Mm-hmm.
And, I think in a big city like that, where there was now public transit and more sugar into the diet, it wasn't unusual that they started to kind of notice this pattern of women that were having, a lot of extra body hair and facial hair growth and huge ovaries.
Yeah.
And I think we're so lucky now because we get to diagnose it with with lab tests and with ultrasound and stuff. But, if you look back at that, they were like so freaked out about it. They thought they had, they had tumors. So they just cut them open.
Oh, I know.
And, would wedge out a big, huge chunk of ovary looking for a tumor.
Yeah.
But then, a fair amount of the time, they stitch it back up, but you've taken out so much of the ovary digging around for a tumor that then you'd lower that ovary's ability to make testosterone for a while, and they actually would ovulate. Some of them, at least the ones that didn't get horrible pelvic adhesions, would get pregnant. But
yes,
we can do it better now.
Yes.
Have you ever done one of those ovarian drilling procedures?
No, that even when I was a resident, that had kind of fallen out of favor, and so we'd try to leave the ovary alone if you will.
God bless America, man. Yeah, I've done two that people begged me to do, and I've regretted it. But I know at least one did get pregnant, but it was with IVF down the road. But does your treatment for polycystic ovary syndrome patients vary according to like what their goals are?
Absolutely.
Yeah. So talk a little bit about that.
So, I mean, really the key difference is, do they want to get pregnant or not? And I think, obviously if someone has no plans for immediate pregnancy, then I try to start teaching on, a low carbohydrate diet and really increasing their intake of lean meats and vegetables. And I think for a lot of people, education about where all these hidden sugars are that they're getting in their diet, because I think I see so many people that think juice is healthy, and I constantly say, it's basically soda with a vitamin in it. It's just sugar. And so really it's a lot of it is aiming at preventative treatment of, there's a lot that every woman can do to stop this from getting worse. And in terms of, typically I see a lot of women that come into the office, not a lot for, trying to get pregnant and they're not successful, but a lot for just really irregular periods. And I feel like, a couple times a week, I'll have somebody who comes in who's new to me and has had, my periods have been every 2 to 4 months for the last couple of years. And when I get them, they're so heavy. And so, they want to get better. They, not necessarily are attached to the idea of having a period or not having a period, but just don't like the unpredictability of it. And then the heavy bleeding when they do get it. And so I find that, once I make the diagnosis of polycystic ovarian syndrome, it's really teaching about lifestyle changes that everybody can do. But then, if someone has no plans on getting pregnant, starting birth control pills is usually the quickest and the easiest. And there's also health benefits to that. I mean, one of the downsides in addition to the trouble with fertility for women with polycystic ovarian syndrome, is that their bodies are constantly in this state where they're releasing estrogen and estrogen and estrogen. And then that down the line will predispose you to uterine cancer. And so giving them birth control pills to balance that out, I think helps a lot of women both to make their periods more predictable and make their periods lighter, but then also helps combat that negative health effect downstream. So
right.
So absolutely, for women that don't have plans to get pregnant, birth control pills and lifestyle changes is kind of the first pass that I do. And then certainly for someone who wants to get pregnant, it's a whole different conversation, because obviously I'm not going to give her birth control pills. And so then I really gear more towards like really, really dialing in the low carbohydrate diet, but then also talking about starting a medication such as metformin, and using that to try to decrease the woman's or increase the woman's insulin sensitivity, and try to get her ovulating again. And then that will fix the periods too. If you're ovulating more regularly, you'll have more regular periods. Yeah. And so it really depends on the goals for that individual woman.
Yeah. Getting that metabolic normalization going, I think, is just so critically important, because, we talk about all this imprinting phenomenon now on kids, and so that, which if you're out there and you're not really familiar with that, you can spend forever looking at this data. But there's the information contained in our genes, and that's our genome. And then there's how our genes are influenced and how the enzymes can read the actual genetic material off the DNA. And that's a lot of that is environmental. And what I really worry about I think that a lot of our population has had environmental exposures, like from, that may have reached back, 2 or 3 generations.
Oh, absolutely.
That are now affecting them. And they're, life was a lot easier for their grandmother to ovulate, but now it's going to be a lot harder for them.
Yeah.
Did you see that paper or hear about, I didn't really actually read the paper, I just saw it in the lay press, about the Dutch people. If you're a Dutch man now and your grandfather was in your great grandmother during the Dutch winter famine of 1944-45. Did you hear about this?
No, I didn't hear about that.
Yeah, this is so cool. Well, it's not so cool if you're a Dutch dude who in that situation, but you're much more likely to be obese or type 2 diabetic if your great grandmother was starved during her pregnancy. So just that imprinting phenomenon of having that food deprivation in pregnancy then can lead, 2 generations down the road to you having to deal with it. So I really think, it's I always tell people, I want you to have a healthy baby. I just don't want you to ovulate. Yeah. But I mean, the ovulation is often sort of the dipstick for the rest of your health. You're not ovulating, but there's reasons for that. Let's fix the reasons instead of the, Yeah, absolutely. Yeah, pretty cool. But I've been poking around about this stuff before this and looking at some of those papers, and there are so many genes that are associated with polycystic ovary syndrome, and so it's sort of a grab bag, and some of us have 2 or 3 of them maybe, and they may have had a purpose back when people had to survive starvation, but now, now you combine that with your mom drinking soda when she was pregnant, and all of a sudden you've got both the gene part and then the epigenetic part that's going to make having a baby much harder for you.
Yeah.
But we get them there. Yeah. What percentage would you say you get to ovulate or get pregnant? Let's say.
I think high percentage. I think if that's really someone's goal, I think, most women are willing to do whatever it takes to get pregnant, as you know. And so I think I would say a pretty high percentage even, can either get pregnant spontaneously then just with metformin, or would see, you or somebody like you in their city and be able to get pregnant then afterwards. I mean, I think it's a very high percentage. Yeah.
I think we kind of quote around 80%. Will eventually do it. For the people who have other problems, like sometimes you will see like endometriosis with it, or now, just like with female infertility kind of being so big, male infertility is getting to be just huge. And sometimes these guys don't have sperm, and so we need to take those people to IVF. But boy, I'm telling you, if you don't pre-treat them ahead of time, it's just, you get a lot of poor quality eggs and poor quality embryos. And then of course, if they're not pre-treated, you're sitting there thinking, well, their whole metabolism isn't going to be that great. And, untreated PCOS patients, that it's not perfect data, but it's, most people will quote around a 50% miscarriage rate. So I think that doing that pre-treatment is really important. Are you using any inositol?
I've started it. I actually just learned about that maybe last year, as sort of an alternative, sometimes maybe adjunct to metformin. And so I have a couple people on it, not enough to really say I have a huge population and experience to go on. But I think especially if people have either are worried about the side effects of metformin, which really is GI distress. I see less of that with the myo-inositol. And I think some people just kind of like the more supplement sort of vitamin type treatment. It is more expensive. And I think that's a barrier for some people.
Yeah. I mean, when I've shopped it online, it's like, it depends. And, and all these manufacturers make all these kind of crazy claims, but I think that if you're using 2 grams twice a day, you can get it, for about $65 to $75 for a 3-month supply.
That's
not bad. I've had a couple of people who are like in that super taster kind of category of patients where like vegetables are super bitter and they can taste flavors and things that other people can't. I've had some of those people say that they felt like the inositol was really bitter to them. But when I tried it, it was kind of sweet to me. I didn't, which structurally,
it's sugar.
It's a sugar. I mean, and for those of you who don't know about inositol, our bodies use it as an intracellular signaler. So it's a second messenger for insulin and for other things too. But it has, it's naturally occurring, but in a lot of things, a lot of people don't eat anymore. So like citrus peel or citrus pulp and beans and stuff like that, and when you process food, you get rid of all that insulin and polycystic ovary syndrome patients appear to have an enzyme system that really ramps up getting rid of it within the ovary. So that may kind of heighten their insulin resistance in the ovary and make the ovary make too much testosterone. So I've been happy with that inositol. And most people don't complain about it. The metformin, some people are like, oh, well, there was a Cochrane database article from November that said, well, we can't really tell you much about this. And, it doesn't really seem to be of that much help. Or maybe I'm confusing that with the inositol Cochrane thing. But, there have been now some meta-analyses that have shown that metformin is not all that great for live birth rate. But I love it because, it changes their nutrition.
Yeah, absolutely.
And, and I just don't think it's a good thing to, march into pregnancy, just sitting there being able to drink orange juice and, eat your Frosted Flakes and bagel for breakfast. I just don't think that's probably good for your baby if you're pretty insulin resistant. So I try to coach him on that and tell him, hey, it's going to be an adjustment period for you, but this is, I had a patient say, hey, this is like antabuse for carbs. For those of you who don't know about antabuse, it's for patients who have alcoholism. If you take it, then you won't drink, because if you get tempted and you drink, you throw up.
You get horribly sick.
Only with metformin, it's diarrhea and nausea. Usually. So, but I don't know. What do you tell people about weight loss then with polycystic ovary syndrome?
It depends on where they're starting from. And I find that weight often is such a loaded thing for so many people because it's so wrapped up in this concept of body image and self-worth and everything. And I do stress that it's helpful, but I also tell people, I don't care as much about what number it says on the scale when you get on it, as much as I care about what you're eating and what you're doing. And if you're active and if you're eating the right things, that is so much better than your BMI is 29 and before it was 32. And it doesn't account for muscle mass. And I think especially women with PCOS with extra testosterone are also more prone to gaining muscle mass if they're active. Yeah. And so BMI doesn't reflect that. And so, and so I don't, I do bring it up because I feel like some people, you definitely weight loss will help, but it's really the diet and it's really the activity level that I see makes a difference.
Yeah. I almost never bring it up now because I just feel like, like you said, I mean, the body image stuff is just, we don't need to, make women feel any more insecure. And it really is, I do think, like I've had people, back when we thought that those numbers were so important, I would write down where they needed to go. And then a lot of the time they just get pregnant before they reach those goals. And then they freak out and they'd be like, oh, now I'm going to lose my baby. And I'd be like, and over time, then I've realized that it really is, if they've changed their nutrition, I mean, there's a big lag there. They'll eventually, they're not going to probably have that miscarriage or that stillbirth or whatever.
Absolutely.
And it is. It's just, I think there's been, we're in a place in society now where we have, in human history now, we have these like superhumans that are more fit than any, but running,
the Ninja Warriors and
and then we're the rest of us are kind of drifting into the being really super unfit. But I tell people that exercise is no good for weight loss, but it's really good for it appears to be really good for dementia prevention and probably for management of your blood sugar. And I think what's the percentage of these folks with PCOS that go on to type 2 diabetes? Pretty high.
Pretty high. Yeah.
So it's interesting. There's some people commenting. Are you seeing the comments on there, Erin?
I'm not. I think because I'm your guest. I don't.
Okay. All right. So there's one who says, how do you manage women who are taking metformin and trying to eat healthy but can't increase the dose to the ideal dose of 1,000 milligrams twice a day because of the side effects of nausea and diarrhea? Is one 500 milligram tablet a day sufficient? We don't really know. You see this all the time too, right? Where they just can't. They can't get there. There's data going back to, I think it was around early 2000s. There were a couple of studies that were published out of Venezuela from a fertility clinic there, and they saw that 1,500 milligrams was about equal to 2,000 with miscarriage prevention and normalization parameters, but. I tell people to take what they can take and then, use the inositol and, do your vigorous exercise, because the vigorous exercise is another really good component in there too.
I agree. I tell people the same thing. I mean, some is better than none and do what you can.
Yeah. And then, how do you feel, there was something about the maternal fetal people, saying stop metformin once you're Did you hear about that?
I did, and it was a real crisis for us because the maternal fetal medicine doctors that I work with really felt like metformin has a place, and there are people that just can't get comfortable with using insulin, and metformin is a great medication for that. And really, it's the studies that showed the worst outcomes with the oral hypoglycemics or the oral gestational diabetes medications like metformin and like glyburide really didn't take into account the patient's comfort level. And if someone's just not going to be able to give themselves shots 4 times a day, it's better to use metformin than it is to just have wildly out of control blood sugars. So, we don't use it anymore because we felt like that for gestational diabetes, because we felt like the position statement that ACOG came out with was so clear that it was just hard to go against it, but we were not happy about it. And I don't know that, within the next few years, they might dial back on that. I just don't know. But yeah, that was a bummer.
Yeah. I mean, here's a drug that's been used safely in pregnant diabetics for, the last,
years.
40 years or whatever.
Yeah.
And it's still approved for treatment of gestational diabetes in most of the European countries, apparently. So at least the Nordics, which I think, typically have a whole lot better health outcomes than we do.
Yeah, anyway. I know. Yeah. I mean, there's a lot of reasons for that.
So,
but
yeah, and I don't know what to tell people about continuing on taking inositol along the way then too during pregnancy. I usually tell them that it's probably not necessary, but I don't, who knows? I mean, it might be helpful but who knows? Have you seen any thin PCOs lately?
Lately, a couple recently. Yeah, I mean, in my practice, they're few and far between. I think you probably get a bigger selection of them than I do, because I think you're getting them from the whole town. But yeah, I do sometimes. Yeah. Yeah,
they're a tough nut to crack. They're about 15% of the PCOs, and they're usually really distraught about it because they're kind of like, hey, your weight loss is supposed to help, because that was the old data. And so they're like, I can't lose any more weight. I'm going to blow away here. But yeah, they're harder. They really do, I think, need that much more full court press deal with the exercise and the metformin and the inositol and the really tight nutrition and stuff like that. And occasionally I'll roll out and do injectable fertility drugs in really low doses for them to kind of, nudge them towards getting one follicle. But boy, if you let them make 2 or 3, your risk of multiples is really I usually will scratch them if they're making 3 follicles or more. And that's a bummer because that stuff is so darn expensive. They're spending with that another $1,000 on the cycle, and then you're telling them to cancel it. But but interesting. Anything else you kind of want to add about PCOS or any other?
I think I think we touched on the big things, and I think of it as, really about optimizing your health before pregnancy, not just to have a healthy pregnancy and to have a healthier baby, but to decrease your risk of complications later in life, so you can be around for your kids, so you can be active and play with your kids and play with your grandkids. Because women with PCOS do have a higher rate, like we talked about earlier, of type 2 diabetes later on in life. And then also a higher risk of getting endometrial cancer younger too. And so I think it's, it's a whole lifelong condition. So I think that's the big thing for me is really about prevention and about making the changes that, we all know that we need to make. And I think for some people just have the genes for whom they need to be more strict about it than the rest of us do.
It's a harsh thing. It makes me think about like when you were in medical school and you saw those, kids with type 1 diabetes, and people would be like, oh, life is so unfair to them. They need to be cut a little bit more slack, and they need to be able to, eat more, junk food like with the rest of the kids. And I remember when I was a fellow, we had to rotate through the regular diabetes clinic, and we got to see, like, the first day, I'll never forget the guy who was in charge of it, who was this really good diabetologist named Chris Sodick, said, now look, you're going to see what we have here at Hopkins are 2 sets of patients who have been managed in 2 completely separate ways. So there was a West Coast version, which was like super tight control. And then there was an East Coast version where they're like, oh, let kids be kids. And, let them,
what I would have assumed.
I mean, I don't know. And maybe I've got it backwards, but long story short is when you went into the rooms with the loose control patients who'd started out with their type 1 diabetes under loose control, oh my goodness. I mean, you'd walk in the room and say, hi, I'm Dr. Hutchison. And then this person who was blind would look up.
Yeah.
or the next one had renal failure and was already on her second transplant. And then, and it was just horrible. But then the tight control people didn't have any sequelae. And it was sort of like, wow. So some people, so making these decisions kind of earlier in your life, I think is really important. And I think for those kids, those parents, like most patients with polycystic ovary syndrome are going to go ahead and get pregnant and they're going to have babies.
Yeah.
But, I always tell them, hey, your kids are going to be imprinted, worse than you were. So, you're going to really need to, watch what food you bring into the house and, make sure they exercise and make sure that they, their control of their nutrition is going to probably have to be as good or better than yours. Mm-hmm. Yeah. Just so we can all stay healthy.
Yeah. Absolutely.
Yeah. I'm getting some comments from, these are kind of interesting. Let me see. So a patient of ours who had gotten pregnant had said, I asked if I needed to lose weight, but he said, no, but exercise and eat healthy. She says, I felt very empowered because with everything that is going on emotionally, I'd been told to lose weight and it was so discouraging. I was swimming several times a week and doing what I could and felt good, but it just happened. My thyroid issues and metabolism are just not helping with weight loss. And, that is so true. Yeah. I tell people exercise is for other stuff for health, but it's not going to help you with weight loss.
No. Yeah, I do too. I mean, you get fit in the gym, you get lean in the kitchen, really. And
yeah. Abs are built in the kitchen. Yeah. Anyway, what else was I thinking about with PCOS? But there's some interesting stuff with all that gene stuff, and in going back with rats. Have you seen stuff with rats like making them have basically sort of type 2 diabetes by feeding them junk food? Yeah. It takes 5 generations to get back to normal. Yeah. Crazy. And then did you see there's some stuff on rats and autism? Mm-hmm. And the way you make rats autistic is you feed them a whole bunch of junk food.
Oh, I know.
And it trashes their good gut flora, so their good gut bacteria go away. And the way they tell if the rat pups, I think this is hilarious, how they tell if they're autistic or not. They put them with their litter mates or paper cups. And if they're happy to associate with a paper cup, then they're autistic. So they have this sort of metric for it. And when they restore the mother's gut flora back to normal, then she goes back to having pups that don't have autism. So I think that, this whole nutrition and pregnancy thing, boy, it's super important for people to try to get those vegetables in and healthier food, Mediterranean type diet. Mm-hmm. Yeah. Not that you can't go, far afield sometimes and have some treats, but, day in and day out, eating a bunch of sweets, I think is really bad comment. Yeah. Bad plan. Yeah. Well, cool. And so, and what do you, like when you give people, are you using letrozole or clomiphene for when you want to get somebody to ovulate that's not ovulating with?
If they're otherwise healthy and sort of unexplained, more clomiphene, and then letrozole typically for older women and more with women that do have PCOS. Yeah. Is sort of what I do. I often would send them to someone like you too. I mean, it really depends, and I feel like to some degree I don't want to waste anybody's time, and I think I would rather they go straight to REI for some cases. Depending on their age too. I think, for older women, I think, don't waste the 3 months with me that you might get for your, typically we tell people 3 cycles, if it'll work, if clomiphene, like ovulation induction is going to work, it'll work within 3 cycles. And then that's sort of the end of my expertise. And so depending on the patient and their age and, if they, what else is going on, I sometimes will just send them straight to you too.
Yeah. Yeah, I'm liking letrozole more and more as I get to using it. And because it just seems like the side effect profile is just so much less. it's the same bag of tricks of, fatigue, and some people get hot flushes, but clomiphene, I've had a couple people who had pre-existing depression who had to get hospitalized again because they got suicidal ideation.
Oh.
So yeah, it's rough. And we've been using more clomiphene now as an adjunct in IVF because we get more eggs with it in low responders, and it's cheap as dirt.
Yeah.
But boy, man, they really complain about it a fair amount of the time.
Yeah.
But at least at those higher doses, you get up to 100 milligrams a day, and it's pretty nasty.
Oh yeah.
Yeah. And the letrozole, I learned from Dr. Crystal Gadd today. We were talking about PCOS patients, and she had done some poking around and has started to use for her patients a higher dose of letrozole than even I had been using.
Oh wow.
So she'll go to 7.5, 10 milligrams a day.
Wow. Yeah.
And because she had given me a link to an interesting article that said that you really got, for the unexplained infertility patients, those higher doses of letrozole were getting them to make another follicle or 2 or 3, which is good. But obviously, if you're going to make a bunch more follicles, then you may want to skip cycles or or at least check with ultrasound before you start them again. On it. But yeah. Well, cool. I think it's been helpful. I think we've used social media for good.
I hope so.
Yeah. Unlike the Russians or whatever. So, anything else you have to add about PCOS?
I think we covered all my big, passionate points about it.
Yeah, maybe one more thing, maybe about exercise. I just want to add. So for women who are ovulatory, the party line now is not to exhaustion.
Yeah.
So I don't know how to define that because, I have these patients who are like ultra marathoners. They go out and they run 15 miles and they're not exhausted. They're okay. Right.
Yeah.
So I don't know. And I've had a couple of those people, do IVF with us multiple times and take home, a bunch of babies. So, but for PCOS women, the party line is vigorous exercise. But what I have been recommending, what I think is a lot easier to incorporate for people is not, going to the gym or going to, because people are busy, and especially then you have a baby and you want another baby, and you're doing all this childcare and stuff. You can't go to the gym for an hour. I mean, it's crazy. So what I've been telling people to do is, short intensity, workouts, like 7-minute workout, which is that free download, and just, do it once a day or at least every other day or whatever. And it's 7 minutes of breathing hard and then you're done. But, that exercise, I do think really helps those muscles become more insulin sensitive, and it may affect a lot of the whole way that that signal transduction even happens in the ovary then too, with all these other cellular messengers around.
Yeah. I'm an advocate of the high intensity interval training.
Yeah. Plus it's, then you get to watch more TV.
Exactly. It's more efficient.
There's more good TV out there now.
There is.
Well, cool. Hey, thank you, Erin.
You're welcome. Thanks for having me on. It was great to see you again.
You bet. It's so nice to see you.
Yeah.
Well, good. We'll have a great rest of your week.
Thank you. You too.
All right. Thank you all for joining us out there.
Yeah. Well, good night, everyone.
Yep. Good night.
Bye.
Bye.